Hi folks, Dr. Patil here and welcome back to PrepLadder NEET Assist platform. In this tiny video module, we will be taking a quick update on lung cancer. Among the solid malignancies, this is probably the most important malignancy that you need to study about. So when you're preparing for NEET Assist, when it comes to malignancies, mostly hematological malignancies are definitely very important. Among the solid malignancies, this is one must not miss topic. Okay. Now, this is a very extensive topic. For an oncologist, it itself is a subject. But for us, we need to concise it and we definitely need to understand what are important areas. So what you need to focus on is the epidemiology of lung cancer and the risk factors in terms of gender and age of presentation, and in terms of the well-established risk factors and the relative weightage of those risk factors. MCQs related to this have been asked multiple times. Okay. After that, pathology is important. The WHO classification of lung cancers is important. And apart from knowing the WHO classification, you also need to know about important tumor markers, because in terms of management of lung cancer, this kind of tumor markers are going to influence the management. So whether a particular marker was expressed, because it is the era of targeted therapy rather than the bland chemotherapy. Okay. Clinical features, there are some important syndromes that we are already aware from the MBBS days itself, and questions related to that can be asked. Then comes the role of diagnosis and screening. What are the indications for screening for lung cancer and what is the modality of screening? That's the important MCQ area. Staging, yes, TNM staging is important for most of the tumors or malignancies. And in case of lung cancer, yeah, this is one of the solid tumors where you definitely need to remember staging. Okay, so I would recommend you to memorize the staging. And last but not the least, treatment. In terms of treatment, apart from knowing what you do for a particular stage, you need to know if a particular tumor marker is expressed, then what is the targeted therapy offered for those cancers. Okay, so this is the summary that you need to learn at the end of this session. So let me begin by taking a quick introduction to epidemiology. Okay, now we have to understand that lung cancer is the most common cause of cancer-related death in United States of America. Lung cancer is the second most common malignancy in USA, but this is the most common cause for death related to cancer in the USA. I cannot say same thing about India, because in India, the most common malignancy overall is head and neck cancer. Okay, and head and neck cancers do have fatal outcome. So that also becomes the most common cause of cancer related death in India. Okay, but for USA, it is lung cancer. Now, lung cancer was not this rampant maybe half a century ago, but during this last several decades, the incidence of lung cancer has steeply increased. In males, it appears that it has kind of started stagnating, but in females, it continues to rise. Maybe because of the rapid rise in the smoking incidence among females. Okay, so that is another important epidemiological point that you need to know. Okay, now coming to the age. The lung cancers are rare under the 40 years of age. Typically, they occur in the 40 to 80 years of age. And after 80, again, the incidence starts decreasing. If there is a question asking you the peak age of presentation, right? So please remember that is around 60 to 75 years. That's the peak age of presentation. And most typical cases are somewhere between 40 to 80 years. Under 40, it is extremely rare. After 80, the incidence rapidly falls off. Okay, so this is the point you need to remember for the exam. Now, in terms of gender, it goes without saying, because the prevalence of smoking is more common in males in comparison to females. Though I agree, in females, the smoking incidence is increasing. But as of now, males are the ones who are more affected than females. So a male has lifetime 8% risk of developing lung cancer in comparison to females who has 6%. So the gender disparity is not great as of now because of the increasing prevalence of smoking in females. Okay, so that's the epidemiology. Now coming to the risk factors. We all understand that 85% of the patients who are diagnosed with lung cancer have history of smoking. Either they're current smokers or they have smoked in the past. So you can say that smoking attributes to the 85% cases of the lung cancer. This is the most potent risk factor as of now. Okay, so in comparison to someone who doesn't smoke, the direct smoking increases the risk by 10x, or I can say 10 times. 10 times the risk increases if you are smoking. Okay, then comes the question, what about the environmental tobacco smoke exposure, or what you call as passive smoking? studies have shown that those who are married to smokers, their risk of developing lung cancer increases by around 20 to 30%. Is it significant? Yes, it is a significant rise, but nothing in comparison to the direct smoking. Direct smoking increases the risk by almost 1000%, and your environmental toxic tobacco smoke exposure increases the risk by 20 to 30%. Okay, but it is still significant and important, but not as important as what I would call as radon gas exposure. Okay, I'll come back to this radon gas exposure when we discuss more about the radiation. Okay. Now, apart from smoking, there can be occupational risk factors. What are the occupational risk factors? People who are working in industries where asbestos exposure is high. So, we have already discussed in the occupational lung disorders about asbestosis, and we did accept that asbestosis is a pre-malignant condition, right? So, asbestos exposure does increase the risk of developing lung cancer. Then, apart from that, arsenic has been known to be a risk factor for development of lung cancer. Exposure to bischloromethyl ether is also a risk factor, and hexavalent chromium as a metal. So mostly metal exposure at workplaces are risk factors. Okay, then exposure to mustard gas and nickel, another metal. So metal exposures at workplaces, particularly where metals can be made into fumes during the workplaces, that can become a risk factor. Okay, then comes the question of radiation. Okay, there are two types of radiations which can be risk factor. Number one, radiotherapy, right? If you had a malignancy and have received radiotherapy, certainly your risk of developing lung cancer increases, particularly when you have hematological malignancies and you received the radiation to the chest or mantle area. That increases the risk of cancer. Okay. The second thing is environmental radiation exposure. Environmental radiation exposure. That's an important risk factor. And most of our homes may be source of the radioactive radon gas. So some of us may be getting more than permissible radon exposure at our homes. If particularly spending a long time at home, working from home and all, you may be getting exposed to this radon gas. And radon gas is now well established as a significant risk factor. So among those who are non-smokers, this is an important risk factor. Okay, and this risk factor, radon gas as a risk factor, is a stronger risk factor than, like when it is beyond the permissible threshold, it is stronger risk factor than the passive smoking. Passive smoking, yes, is a risk factor, but in comparison to that, radon gas becomes a much more stronger risk factor. Okay. Apart from that, in non-smokers, there is another important risk factor that one need to be aware about, that is biomass fuel. So when you use biomass fuel for cooking, right, that exposure can also be a risk factor, particularly when bituminous coal is used. Bituminous coal is used for cooking purpose. That smoke exposure can be a risk factor in comparison to other forms of coal or even using the wood. But when you're using bituminous coal, it is definitely a risk factor because it might have certain hydrocarbons which have a pre-malignant, which have a oncogenic potential. Okay, so these are the risk factors. After the risk factors, it is time for us to look at some extra contributors. What are the extra contributors? Diet. Is diet a risk factor? Difficult to say. Generally, we understand that diet which is lacking in fibers, which is high in fat, which is high in carbohydrates, are considered as risk factor for several malignancies, but there is no study to prove that lung cancer risk increases because of improper diet. And we have to also note that certain diets have been studied to say if the lung cancer prevalence can be reduced in those people who are on those diets, like diet high in fruits and vegetables. Diets high in fruits and vegetables do reduce the colorectal malignancy risk, but not the lung cancer risk. And also please note, beta carotene and other antioxidant supplements have also been tried as a preventive measure for lung cancer, and studies have shown that supplementation with multivitamins or beta carotene or other antioxidants actually not only failed to show the beneficial effect, it showed harm, increased incidence of lung cancer in those patients who received beta carotene. So it is not advisable. Okay, so diet, we don't have any evidence to directly link to the increased incidence or beneficial effect. We have an evidence of harm with beta carotene supplementation. Okay, then coming to the role of genetics. It has been well established that people who are diagnosed with lung cancer are often having family members who are also at increased risk of lung cancer. Particularly the first degree relatives have a very high risk of developing lung cancer. So what are the genetic markers which we can identify or study to identify the risk of lung cancer? Number one, most of these lung cancers are because of the exposure to carcinogenic substances, mostly from the smoke. Now, those carcinogenic substances are generally metabolized in the liver, right? So, one of the important metabolic system in the liver is the cytochrome P, particularly like P450. Out of that, one variant called as CYP1A1 or cytochrome P450-1A1. Certain polymorphic variants of this might turn your carcinogenic substances into more potent carcinogens, and that might increase the risk of lung cancer. And presence of oncogenes and lack of or suppression of the tumor suppressor genes can also be contributors. So we have known that mutations in P53, MYC gene and BCL2 are associated with the small cell lung cancer, and the expression of EGFR, KRAS and P16 are associated with non-small cell carcinoma of the lung. Okay, so this is important because in terms of management, these are going to influence particularly expression of EGFR, right? So in the era of targeted therapy, if there is a tumor which is expressing EGFR, then we use specific tyrosine kinase inhibitors so that the lung cancer can be treated. Okay, so these markers are important MCQ point. What are the markers expressed in small cell carcinoma and what are the markers expressed in non-small cell carcinoma? I'm just reiterating again: P53, MYC and BCL2 mutations, small cell lung cancer; EGFR, KRAS and P16, non-small cell lung cancer. Okay. With this, we come to the pathology of lung cancer. WHO classifies lung tumors into several types. Among them, we are particularly talking about the epithelial tumors. Okay. Among the malignant epithelial tumors, we have 4 broad types. Those are small cell lung cancer, adenocarcinoma, squamous cell carcinoma, and large cell lung cancer. Okay. All these 3 put together, adenocarcinoma, squamous and large cell carcinoma, we call them as non-small cell lung cancers. In the exam, they might ask you what is the source of origin of these tumors, from which cell small cell lung cancer is originating, from which cell adenocarcinoma is originating, from which cell squamous cell carcinoma is originating, and from which cell large cell carcinoma is originating. That's an important MCQ area. So let us see from which cells these are originating. Now, the small cell lung cancer is originating from the neuroendocrine cells. And because it is originating from the neuroendocrine cells, please remember there is a high risk of developing paraneoplastic syndromes or paraneoplastic manifestations. Why? Because neuroendocrine tumors or neuroendocrine cells are known to secrete various neuroendocrine substances or hormones. Okay. Then coming to the non-small cell lung cancers, it is the adenocarcinoma which is originating from the alveolar type 2 cells. It is originating from type 2 alveolar cells. And on the other hand, the squamous cell carcinoma is the one which is originating from the basal epithelial cell. And the large cell carcinoma is originating from various epithelial cells. Okay. So is that clear? Why do we have higher prevalence of paraneoplastic syndromes in case of small cell lung cancers? Because it is originating from the neuroendocrine cells. Okay. Now, after this, I'm just taking you quickly through the WHO classification of lung malignancies or lung tumors precisely. Okay. So the lung tumors are classified as epithelial tumors and soft tissue tumors, mesothelial tumors and miscellaneous tumors. Our area of interest right now is epithelial tumors, and among them it is the malignant tumors. So WHO classifies malignant tumors as small cell carcinoma, that is one category. Then you have squamous cell carcinoma, that's one category. Then small cell carcinoma, that's the second category, which can be further subdivided into oat cell carcinoma, intermediate cell type and combined oat cell carcinoma. Then the third category we have is adenocarcinoma, which can be again further categorized as acinar, papillary, bronchoalveolar and solid carcinoma with mucin formation. Okay. Fourth one is your large cell carcinoma, which can again be further divided into giant cell carcinoma and clear cell carcinoma. Fifth, we also have adenosquamous carcinoma, where both expression of the adenoid cells as well as your squamous cells is occurring. And then you have carcinoid tumors, bronchial gland carcinoma and other miscellaneous things. right? Our area of interest is mainly the first four: squamous cell carcinoma, small, adeno, and large cell carcinoma. Okay, this is WHO classification. Now, there can also be a question asking you which one is most common type, right? Is it the small cell carcinoma or is it the non-small cell carcinoma? And if it is non-small cell carcinoma, among them, which is most common? Historically, we used to say that non-small cell carcinomas, lung cancers, are more common than small cell lung cancers. And among the non-small cell lung cancers, it used to be squamous cell carcinoma, which was most common in the past. But in last several decades, adenocarcinoma has overtaken. So right now, it is the adenocarcinoma, which is currently the most common lung cancer type. It is the most common lung cancer type. Okay. So lung cancer, around 85% are non-small and 15% are small. Okay. And among the 85% that are non-small, 70% of them are usually non-squamous and 30% are squamous. And among the 70% which are non-squamous, 90% are adenocarcinoma. So that makes it the most common lung cancer type. So adenocarcinoma is the most common lung cancer currently, right? This is a very important potential MCQ point. So please remember this point. Adenocarcinomas are the most common lung cancer type currently. Okay. Then reminder, 10% of the non-squamous are the large cell carcinomas. Okay. So now we know the relative prevalence of these individual cancers. Then comes the question of the difference between the small cell and non-small cell lung cancers. Important things to note. We have already learned that non-small cell lung cancers account for around 85% and around 15% are the small cell. Second thing, there are classically 3 subtypes of small cell. We have just seen that, and several subtypes in case of non-small cell. Okay. Most important MCQ point is this. The small cell lung cancers are usually centrally located towards the hilum or towards the mediastinum, right? And because they are centrally located, they are known to present with certain clinical features, like, for example, superior vena cava syndrome. Because it is most likely to be presented towards the centrally located, it is more likely to compress the superior vena cava. So patient is more likely to present with superior vena cava syndrome if it is a small cell cancer. On the other hand, your non-small cell cancer types may be centrally located or peripherally located. So when you have a peripherally located tumor, it is more likely to be non-small cell than small cell. And that also means that certain peripheral manifestations, like, for example, Pancoast tumor, apical tumor, presenting with the compression of brachial plexus and the sympathetic chain leading to Horner syndrome, is more likely to occur with non-small cell because they are peripherally located. And small cell being centrally located is more likely to present with superior vena cava obstruction. I don't mean that the non-small cell do not present with superior vena cava, because they can also be centrally located. They can also present. But among the patients of superior vena cava obstruction that you see, the small cell definitely, in terms of numbers, outweighs the number of cases of non-small cell. Okay. In terms of tumor behavior, small cell are very aggressive and mostly they are like surgically not amenable. So whenever you talk about management of small cell, it's not about surgery. It's about chemotherapy plus or minus radiation. On the other hand, non-small cell lung cancers can be either fast growing or slow growing. For example, the adenocarcinoma is slow growing. But though it is growing slow, it metastasizes early. On the other hand, the squamous cell carcinoma may be relatively fast growing. But because if you find them localized, they are amenable for surgery. So when it comes to non-small cell lung cancers, certain stages you do offer surgery like lobectomy and all. But surgery doesn't come into picture when you talk about small cell lung cancer. Okay. In terms of staging, the TNM staging is less relevant when it comes to small cell carcinoma. So here you simply stage it as either limited or extensive disease, but when it comes to non-small cell lung cancers, staging typically follows the TNM staging. Now, last but very important point, not the least point, that is, when it comes to small cell lung cancer, I have multiple times told you surgery has limited role. Treatment is usually in the form of chemotherapy with or without radiation. On the other hand, the non-small cell types, treatment can include surgery if the tumor is surgically amenable. Apart from that, there can be chemotherapy or radiation. And obviously, we're talking about the era of targeted therapy. So we will be looking at presence of specific markers, and according to that, we will be treating them. Okay, so that is the basic difference. Now, having understood the basics of lung cancer, it's time for us to learn about the screening of lung cancer. So we know that smoking is the important risk factor. So if at all we are thinking of screening, most likely we are screening those patients who have significantly smoked. Now, who are the ones who have significantly smoked? For understanding that, we look at the pack years. Those who are not aware of or those who have forgotten what is pack years is the number of packs of cigarettes smoked per year into the number of years the patient has smoked so far. And those who don't know how many cigarettes are there in per pack, it is generally believed to be 20, right? So if a particular patient has, let me say, smoked 2 packs per day and he has smoked for 15 years, that means 15 into 2, that becomes 30. So this patient has 30 pack years of smoking history. Now, the risk of lung cancer exponentially increases after 30 pack years. So that's why whenever we are thinking of screening, we will be looking at screening of those people who have smoked for more than, like those whose smoking history encompasses more than 30 pack years of smoking. Okay. So it is recommended for people with history of 30 pack, more than or equal to 30 pack years of smoking. They can be either current smokers, like they have total 30 pack years of history and they're currently smoking, they continue to smoke. Or the second thing is those who have quit smoking within last 15 years. Okay, now comes the question, what about those who had 30 pack years history of smoking but they have quit more than 15 years ago? Should we be screening them? The answer is no. If they present with some specific symptoms that make you think that patient may be having a lung cancer, maybe you can investigate it as a suspected case of lung cancer. You don't need to do the screening. But those who have quit within 15 years, we need to do that. Why? The reason is, once you quit smoking, as soon as you quit smoking, the risk of lung cancer starts declining. Okay. As soon as you quit smoking, the risk of lung cancer starts declining. But you have to also note that the risk never becomes zero. The risk never becomes equal to someone who has never smoked. Someone who has never smoked will always have low risk of having the lung cancer in comparison to someone who smoked in the past. But after 15 years of quitting, the risk decreases by more than 80 to 90% of what it was when you were actively smoking. So because the risk decreases significantly after 15 years of quitting, so post 15 years, you don't need to screen. Within 15 years of quitting, you definitely need to screen. Okay. Now, what is the screening modality of choice? The screening modality of choice, is it X-ray, is it CT, or is it PET scan, or is it the bronchoscopy? The answer should be what is known as low dose CT. Low dose CT, because X-ray is far insensitive for detection of the lung cancers, because most of the lung cancers, even when they occur, they are generally asymptomatic if the tumor size is small, and X-ray may not be able to pick it up always. So we have to go with CT, but the conventional CT definitely includes high radiation exposure, and because it is a screening protocol where you have to frequently keep repeating the CT scan, radiation exposure dose becomes relevant. So that's why we resort to something called as low dose CT, where low dose radiation exposure is done. Okay. Then comes the question, what is the frequency of doing this CT scan? So frequency is annual. Frequency is annual. So every year this patient should be undergoing a low dose CT scan. When do we stop? If the patient has quit smoking and he has completed 15 plus years of abstinence, then maybe you can stop screening. Okay. One more point I forgot to tell you is the age of screening. So the screening is recommended for someone who is in the age range of 60 to 75 years. Because that's the time where most of these lung cancers appear, or that's the peak age of presentation of lung cancers. So after 75 years, screening is not generally recommended for initiation, because most likely the treatment versus benefit or early detection versus the management, the risk benefit analysis doesn't favor the screening method. So if patients 75 plus can present with lung cancer, but once they present with symptoms, maybe you can treat. Screening is not recommended. Okay, so this is about the screening for lung cancer. Now, coming to the clinical features of lung cancer, someone who has already developed lung cancers, what are the symptoms that these patients are going to present with? First MCQ point is, what is the most common symptom? And that is cough. That's the most common symptom. Majority of patients who have small lung cancers are generally asymptomatic. They may be incidentally detected when you do imaging of the chest for some other complaints, or when you are imaging the whole body for some other complaints. But if they present with symptom, the most common symptom is likely to be cough, because the presence of the tumor irritates or mechanically distorts the lung architecture of the airway architecture, and it causes irritation of the mechanical cough receptors, and that can trigger the cough. So that's the most common presenting complaint. Some patients might present with dyspnea, and in fact that's the second most common presenting complaint of patients of lung cancer. First most common is or cough. Okay. Apart from that, patients might present with chest pain. Whenever a lung cancer patient presents with chest pain, there are two possibilities. Either there is pleural involvement, the tumor has now encroached onto the pleura, or the second possibility is tumor invasion of the chest wall. Because the mediastinal lymph nodes and all are pain insensitive. So the tumor itself or the tumor invasion of the mediastinal lymph nodes is unlikely to produce pains. But pleura being pain sensitive or the chest wall being pain sensitive, when they are invaded, it produces chest pain. Okay. Now, tumor might invade an adjacent blood vessel and can cause hemoptysis. Patient can present with scanty to massive hemoptysis depending on where is the tumor located and whether it is invading a vein or an artery, and whether the invasion is affecting a larger blood vessel or a smaller blood vessel. But hemoptysis can be one of the presenting complaint. Okay. Then patients might also present with hoarseness of voice because of the compression of the recurrent laryngeal nerve. So if you have a patient who presented with cough and hoarseness of voice, one of the important differential diagnoses you need to think of is also lung cancer. Patients might present with pleural effusion. Around 15% of patients have some degree of pleural effusion if they have a early stage cancers at presentation. On the other hand, it might exceed 50% once they have advanced malignancies. Because advanced malignancies become extensive, pleural involvement is much more common, and they might have significant pleural effusion at the time of presentation. Okay, these are the important things. So cough is something that you need to keep in mind as the most common symptom. Apart from that, there are two specific syndromes that we need to remember. First one is presence of Pancoast tumor. What is Pancoast tumor? It is a lung tumor which is located in the apex. And what is it more likely to be? Pancoast tumor is more likely to be the non-small cell lung cancer. Most likely it is a squamous cell carcinoma. I have already told you that the non-small cell lung cancers are more likely to be peripherally located. So they can be located at the apex or towards the pleura rather than towards the mediastinum. That's why it becomes the most common cause for the Pancoast tumor. Now, the presence of Pancoast tumor can cause certain complications. Okay, before we go there, just look at this X-ray. This is a typical X-ray of a patient with Pancoast tumor. You can see a tumor which is present in the lung apex here. Right? Now, if the tumor is present in the lung apex here, it can compress some structures. What are the structures? It can compress the brachial plexus. And because of that, it can cause a neuritic pain and also weakness of the muscles of the hands particularly. Okay. And then apart from that, it can compress the sympathetic chain, stellate ganglion and sympathetic chain. Stellate ganglion and sympathetic chain, and because of that, this can lead to development of what is called as Horner's syndrome. Horner's syndrome. So there can be an MCQ giving this chest X-ray image and this Horner's syndrome image, and they might ask, among the possible different types of lung cancer, which one is it most likely to be responsible for this patient's presentation, right? So we now know that it is the Pancoast tumor. Pancoast tumor is most likely to be squamous cell carcinoma. Okay. So this is a typical patient of Horner syndrome that you are seeing here. Because of the sympathetic chain disruption, you are seeing the ptosis here. Look at the left eye and look at the right eye of the patient. You can see there is ptosis. So ptosis is one component. The second component that you can notice here is, in comparison to the left eye, the right eye, there is meiosis. So ptosis, meiosis, and the third thing is anhidrosis. So this constellation of symptoms is what we call as Horner syndrome, and in this case it is because of the compression of the sympathetic chain by the Pancoast tumor, most likely to be squamous cell carcinoma. Okay, so this is one syndrome, very important MCQ topic. And the other syndrome that you need to know is superior vena cava obstruction. First MCQ point is, which tumor is most likely to present with superior vena cava obstruction? Obviously something which is more centrally located, like you can see in this image, a tumor more centrally located is the one which is likely to compress the superior vena cava. So which tumor is likely to be centrally located? Obviously it is going to be small cell lung cancer more than the non-small cell lung cancer. We have already learned that non-small cell may also be centrally located, but it is most likely to be small cell lung cancer. Okay. Now, if the superior vena cava is compressed, what are the clinical manifestations that the patient is going to present with? If you compress the superior vena cava because of the tumor, then the flow of blood from the veins of the upper extremities and to some extent the abdomen, right? Those veins into the right atrium is disrupted. So pressure inside these veins starts building up. So those veins get engorged. And because the venous return is disrupted, there can be edema, right? There can be puffiness or edema of the face, then upper torso, and to some extent abdominal wall. And because of this obstruction, now the veins start getting, like the blood starts getting diverted towards the superficial vein. So you will see superficial veins which are engorged. And when in doubt, you can ask the patient to raise his arm, and raising the arm will precipitate the congestion and cyanosis of the face if it was not already there, or if it is already there, it's kind of straightforward. Okay. Apart from that, when you look at the flow of blood from these engorged veins, it is, if you like block it proximally and release, the blood will flow towards the inferior vena cava. So superficially it is trying to reach the inferior vena cava and return to the heart. Okay. So that is your superior vena cava syndrome MCQ point. Which subtype of lung cancer is most likely to be presenting with superior vena cava obstruction? And that is small cell lung cancer. Okay. Now, this is a typical image of a real image of a patient having the superior vena cava obstruction with the small cell lung cancer. You can see all these engorged veins, facial pathora, and the cyanosis on the face. Okay. Now, apart from those two syndromes, patients might also present with paraneoplastic manifestations and metastasis. Now, what are the important paraneoplastic manifestations? Patient might present with hypercalcemia. What could be the cause for hypercalcemia? Present secretion of the parathormone related peptide or PTH related peptide. Okay, that could be the reason for hypercalcemia, literally behaving like parathormone. Okay, then patients can present with SIADH, Cushing syndrome because of the secretion of ACTH. Patients can present with hypertrophic obstructive cardiomyopathy. So lung cancer can have clubbing, and it can have a severe grade of clubbing, what we call as hypertrophic obstructive. The next manifestation that you need to be aware of is hypertrophic osteoarthropathy. So lung cancer can cause clubbing, and a severe form of that, hypertrophic osteoarthropathy, can also occur in patients with lung cancer as a paraneoplastic manifestation, mainly because of the expression of EGFR, right? That's what we had been repeatedly talking about in this lesson. EGFR expression can cause hypertrophic osteoarthropathy and severe clubbing. Dermatomyositis, we all recognize it as one of the malignancy related myopathies. So dermatomyositis can occur as a paraneoplastic manifestation and a well recognized entity, Lambert-Eaton myasthenic syndrome. So all these are paraneoplastic manifestation. MCQ point is, which type of lung cancer is most likely to present with paraneoplastic syndrome? And we know which tumor is coming from the neuroendocrine cells. The tumor that is coming from neuroendocrine cells is small cell lung cancer. So that is the one which is most likely to present with paraneoplastic syndrome because of production of all these substances. Clear? Now, coming to the diagnosis of lung cancer, where you're already suspecting the lung cancer based on patient's clinical symptoms and presence of risk factors. How do we evaluate further? How do you go further? What is the initial investigation that you would be doing? Now, there are three objectives to achieve here. Number one objective, you need to identify the tumor. So for that, you definitely need an imaging modality. So what is the initial imaging modality of choice? We need to know. And after that, if you know that this is most likely to be a malignant tumor, then you also need to classify it histopathologically. So you need to achieve tissue sample. Tissue sampling is essential. And the third objective to achieve is staging. So the initial investigation that you did for tumor identification, will it be good enough for the staging, or you need to go ahead with something much more advanced? Okay. Now, what are the initial investigations that you can do? Chest X-ray is often done as a starting point when someone presents with cough, dyspnea, weight loss, and other symptoms. But chest X-ray is not sensitive, so may not be able to pick up a malignant tumor. So next best investigation is the CT scan, the high resolution CT scan. Okay. The other thing you can think of is PET CT. Now, between the three, we are all familiar that PET CT is the one which is superior. Now, PET CT, apart from tumor identification, it will also tell us about the extent of disease. So, PET CT is good for, or it will facilitate staging better than the CT scan. If at all you are doing the CT as the initial investigation of choice, make it sure that you also include, apart from chest, you include the abdomen in the field of view. The reason for that is you can identify the liver mets if you are including the abdomen in the field of view. Okay. Now, PET CT, generally whole body PET is considered. And please note that PET CT is good for detecting metastasis as well as a primary tumor, except one location. What is that location? That is your intracranial mets. If there are intracranial mets, PET CT is inferior. So what is the best investigation of choice for detection of intracranial mets? Either it is MRI or CT, and MRI is certainly going to be better. So if you are thinking of the brain metastasis because of the lung cancer, you should be going ahead with an MRI. Don't depend on the PET CT. For every other region, thorax, abdomen, and other extremities, bones, you can definitely depend on the PET CT. Okay. Now, once you have identified tumor, you need to go ahead with the tissue sampling, mainly to classify into non-small cell lung cancer and small cell lung cancer. Now, the important reason for this differentiation is in terms of management. If it is the small cell lung cancer, only if it is a limited disease, surgery might hold some role. Otherwise, it is mostly chemoradiation. But if it is the non-small cell lung cancer, initial stages, stage 1 to 3, you might consider surgical intervention like lobectomy. So this tissue sampling is very important. And the tissue sampling will also help you to identify expression of certain markers so that you can give the targeted chemotherapy. Now, what is the modality of acquiring the tissue? The modality of acquiring the tissue depends on the site of the tumor. Tumor may be quite peripherally located. So in that case, like if the tumor is peripherally located, then it is easy to access. What are the modalities that can be used for accessing the tumor which is peripherally located towards the pleura? Then you can do a CT guided transthoracic biopsy, right? You can do a CT guided transthoracic biopsy. That's a possibility. Or other thing you can do is VATS, video assisted thoracoscopy, and then take the biopsy from the affected lesion. Obviously, between these two, VATS is the best thing you can go for. But if it is easily amenable for CT, then you can avoid the surgical intervention, right? And if it is more located towards the mediastinum or centrally located, then it may be amenable through transbronchial route, transbronchial biopsy. For that, definitely you can take the guidance using the EBUS. So EBUS TBNA may be better route. There are several modes of acquiring the tissue sample, not restricted to the ones that I'm talking about. I'm just giving you a gist, right? So someone who is well experienced in getting the tissue samples from the thorax should decide what would be the best approach to get the tissue sample. But getting the tissue sample and biopsy done is very, very important, and also identification of those specific markers on the tumor tissue. Okay. After that comes the question of staging. Now, staging modality that we follow for the small cell and non-small cell is different. For non-small cell lung cancer, we follow the TNM staging. And for the small cell lung cancer, basically we follow, or we classify it into extensive disease and limited disease. Okay. So you will call it as limited when the small cell carcinoma is affecting only one side of the lung, like only one hemithorax or one side of the lung. There may be lymph node involvement, up to supraclavicular lymph node involvement may be there. So if there is a tumor which is restricted to one lung and there may be involvement of lymph nodes, including supraclavicular lymph nodes, you call it as limited. It will be called as extensive when the tumor also spreads to contralateral side or contralateral lymph nodes or contralateral lung, or there is extensive metastasis. Then you call it as extensive disease. So if there is a tumor on the right lung and that tumor has spread to the left lung, or it has caused lymph nodes on the contralateral side, including the contralateral supraclavicular sides, or there are distant metastasis, you will call it as extensive small cell carcinoma. In terms of management, if it is a limited, there is still scope of surgery. A lobectomy with lymph node clearance can be done. But if it is extensive, then these patients are only treated with chemotherapy, conventional chemotherapy, plus nothing targeted here, plus or minus radiation, depending on the extent of the disease. That would be the approach to management of a small cell lung cancer. Nothing more specific or nothing more extra you need to know. But coming to the non-small cell lung cancer, TNM staging is important, and this is one lung cancer where you, like, this is one malignancy where you need to know the staging. So obviously here we will be looking at the size of the tumor, status of the lymph nodes, and metastasis. Now it is classified as stage 1 to 4, and stage 1 to 3 there is no metastasis. So that means all these stages will have M0. Okay. Now let us look at how we characterize tumor, how we characterize node involvement, and how we characterize metastasis. So according to the 8th TNM classification, the tumor is said to be TIS if it is in situ tumor, carcinoma in situ. As long as it is not in situ and there is an identifiable tumor, it will be staged T1 plus. So it will be called as T1 if it is less than 3 centimeter in its largest diameter, less than 3 centimeters. So if it is less than 1 centimeter, you will call it as 1A. If it is 1 to 2 centimeters, you will call it as 1B. And if it is 2 to 3 centimeters, you will call it as 1C. Okay. Now coming next to the T2. T2 broadly means 3 to 5 centimeters. Tumor size is 3 to 5 centimeters, where you can have a T2A and T2B. A is 3 to 4 centimeters and B is 4 to 5 centimeters. Okay. Then comes the T3. T3 is obviously going to be more than 5 centimeters, so it is 5 to 7 centimeters. If it is between 5 to 7 centimeters, you will call it as T3, and it will be called T4 if it is more than 7 centimeters. Clear? Less than 3 centimeters, T1, further classified into T1, A, B and C. Less than 1 centimeter, 1 to 2 centimeter, and 2 to 3 centimeters, you are calling it as A, B, C. T2 is 3 to 5. There again 2A and 2B. 2A is 3 to 4 and 4 to 5. 2A, 2B. Then when it is more than 5 centimeters up to 7 centimeters, you are calling it as T3, and when it is more than 7 centimeters, you are calling it as T4. This is about characterization of the tumor size. Now coming to the lymph node involvement. Okay, so lymph node involvement will be called as N1 if ipsilateral peribronchial. See, I'm not talking about the lymph nodes in the mediastinum. We're talking about peribronchial lymph nodes, right? Bronchial tree, peribronchial lymph nodes, and or hilar nodes. Inside the lung, nodes may be there. So let us just draw an image. Lung, trachea, bronchial tree, and mediastinum, heart or something, lung again. So if there are peribronchial lymph nodes, not the mediastinal lymph nodes, or the hilar lymph nodes, or intrapulmonary lymph nodes are there, then you will be calling it as N1. Clear? Okay. Then it will be called as, and again only ipsilateral side. Contralateral involvement, it's not N1. Then you will call it as N2 when ipsilateral mediastinal or subcarinal nodes are involved. So once, if you have ipsilateral, mediastinal and subcarinal nodes involved, then you will call it as N2. Okay, so what is happening in N2? N2, apart from the N1 lymph nodes, there is involvement of ipsilateral, subcarinal lymph nodes or mediastinal lymph nodes. So then you will call it as N2. Okay. When there is contralateral, mediastinal, hilar or ipsilateral, contralateral, scalene or supraclavicular lymph nodes are involved, you will call it as N3. So if opposite side lymph nodes are also involved, it is N3. Or if ipsilateral, scalene or supraclavicular node. Same side, supraclavicular nodes involved, that will also be called as N3. That is with respect to lymph nodes. Now coming to the metastasis, right? You will simply call it as M1 when there is a distance metastasis present. It will be called as M1A if the tumor in contralateral lung or pleural pericardial nodule or malignant effusions develop. So it is M1 when there is a primary tumor, let me say on the right side, and left side also you get a tumor, then it's called as M1. Or if there is malignant pleural effusion or malignant pericardial effusion, or if there is a pleural or a pericardial nodule appearing, it will also be called as M1A. Now coming to M1B. M1B is where the metastasis is now beyond the thorax. Single extrathoracic metastasis, including single non-regional lymph node. Clear? So either the extrathoracic metastasis, which is single, including single non-regional lymph nodes. M1C is where multiple extrathoracic metastasis in one or more organs are occurring. So M1C is where you have organ metastasis, right? So this is the metastasis staging. So we have learnt about the tumor staging in terms of size. You need to remember that. We have learnt about the lymph node staging and we have learnt about the M or metastasis staging. Now let us see how do we put that together to call different stages of lung cancer. Okay, stage 0 is a type of lung cancer where the tumor is in situ, carcinoma in situ, obviously no lymph nodes, no metastasis. So the first place where metastasis appears is stage 4. So there is no metastasis from stage 0 to stage 3. There is no mets. Please remember this. Okay, so stage 4, if any degree of mets present, that's stage 4. Okay, so stage 0 is only carcinoma in situ. Stage 1 is divided into A1, A2 and A3. So 1A1 is where a lymph node involvement is not there in any of these stage 1s. What you see is the tumor is T1A. What have we learnt about T1A tumor? T1A is less than 1 centimeter. So stage 1A1, the tumor is less than 1 centimeter. There is no lymph node, no metastasis. 1A2, we have a tumor which is T1B. That means it is 2 to more than 1 centimeter, 1 to 2 centimeters, 1B. And 1C is when you have a 2 to 3 centimeter sized tumor. So in stage 1A2, you have a T1B. That means you are having a 1 to 2 centimeter tumor, no metastasis, no lymph nodes. Then stage 1A3, you have T1C tumor. That means 2 to 3 centimeter tumor, no lymph node, no metastasis. So that is stage 1, right? So stage 1 tumor is always T1 for the stage 1. And that means it's always less than 3 centimeters. Then coming to stage 1B, the first category which could be stage 1B is tumor with a 2A size. Now the tumoring sizing for the stage 2 or T2 was 3 to 5 centimeters. So 3 to 4 is 2A, 3 to 4 centimeters is 2A and 4 to 5 centimeters is 2B. No lymph nodes here also, no mets here also. Okay, 2A, there are no lymph nodes, no mets. Coming to stage 2B. In stage 2B, you can have a T1A to C tumor or T2A tumor or T2B tumor, but you have N1 lymph node. What did we learn about N1 lymph node? N1 lymph nodes, if you remember this image, are the lymph nodes where the tumors are either like nodes are intrapulmonary or they are ipsilateral peribronchial or hilar, but not into the mediastinum or contralateral lungs. So that's N1. So N1, if it is present, it is going to be 2B. So this is a point to remember. If N1 present, the minimum stage that it could be is 2B. Minimum stage it could be is 2B. And any T3 tumor will also be, like, irrespective of the node involvement or metastasis, T3 tumor will also be called as 2B. Now coming to the stage 3, there are two types, 3A and 3B. So in 3A, you have a T of any size 1A to 1C or 2A or 2B. So that means up to less than 1 centimeter to 5 centimeter tumor with N2, that can be stage 3A, or a T4 tumor with no lymph nodes and metastasis, that can be stage 3A, or T3, T4 tumors with N1. N1 we have already learned what is that. That will be called as stage 3A. Now coming to stage 3B, again tumor can be 1A to 1C, 2A or 2B, but the node status is N3. That means the lymph nodes are affecting the contralateral side also. Okay. Then we have stage 3C. In 3C, we have tumor ranging from T3 or T4 with N3 lymph nodes. That will be stage 3C. Now, stage 4A and 4B, they will definitely have metastasis. Regardless of the tumor size, regardless of the lymph node, if there is metastasis, it is going to be called as stage 4. So, in stage 4A, you have either M1A or M1B metastasis. And when you have a M1C, that means organ involvement, that will be called as 4B. So, this could be an important MCQ point. So, lung carcinoma plus mets to organs, let me say brain or liver, will always be stage 4B. Okay, so this is the TNM staging according to the 8th edition of TNM staging for lung cancer. Okay, I do understand it takes some time for us to memorize and remember this, but it is a worthwhile effort because you might anticipate a question on this. Okay, after staging comes the question of management. So we have already learned the management of basic management of lung cancer, right? So what is the management? Depends on histopathology. If it is small cell lung cancer, what do we do? If it is extensive, if it is limited. If it is limited, you can still consider surgical exploration and chemotherapy plus minus radiation. And if it is extensive, no role of surgery. Definitely you will be giving chemotherapy plus minus radiation. Okay. On the other hand, if you are thinking of small cell lung cancer, okay, so let me tell you, if it is stage 1 to stage 3, surgery is to be considered if it is technically feasible, like risk benefit. But if it is feasible, you can consider surgical exploration. If it is a small tumor, tumor excision, up to lobectomy can be practiced if it is stage 1 to 3. If it is stage 4, A or B, then it is palliative chemo plus minus radiotherapy, right? But in 1 to 3 patients, apart from surgery, you can also think of chemotherapy, which could be target specific. Okay, so it could be a targeted chemotherapy depending on the expression of tumor marker. So one tumor marker you will always be testing is EGFR, right? EGFR, ALK, PD1 and PD1 ligand. So these are the important markers you will always be testing, and depending on that you can decide what chemotherapeutic agent you will be choosing. So let us see those chemotherapeutic agents that are available with us. So if the EGFR mutations are there, there are 4 or 5 types of EGFR mutations. So mutation can be affecting exon 18, 19, 20 and 21. What we know is the exon 20 involvement is generally resistant to tyrosine kinase inhibitors. So please note this point. If there is a EGFR mutation involving the exon 20, where you have this T790M mutation included, these are usually resistant to tyrosine kinase inhibitor, TKIs. This is a potential MCQ point. Okay, so they might give you a question where the patient is diagnosed with non-small cell lung cancer and his tumor markers tell you that he has a mutation in EGFR and the mutation is mainly the T790M mutation or the exon 20 mutation. Then how do you treat? So in those patients who are resistant to TKIs, obviously it's not worthwhile trying to give them TKIs. Surgical exploration, depending on the stage 1 to 3, you can definitely do that. And apart from that, you can consider conventional chemotherapy, or based on presence of other expression of other targeted molecules, you can choose the specific treatment. Okay, but those who have 18, 19 and 21 mutations, they can be treated with drugs like erlotinib, gepitinib, afatinib and osimertinib. Now among these drugs, it is the erlotinib which is recommended as the first line treatment of non-small cell carcinoma of the lung involving the exon 18, 19 or 21 mutations or EGFR expression, right? So this is a MCQ point again. What is that? What is the first line agent? First line agent, if EGFR mutations are present, where the EGFR response is known, not the ones with the exon 20 mutations, then the drug of choice is going to be erlotinib. The other drugs we know is gefitinib, afatinib, and osimertinib. Now these EGFR 18, 19, 21 mutations are typically more common in Asians. So we are more likely to be getting benefit from the erlotinib. More common in women, particularly women who have never smoked. And this is more likely to be expressed in adenocarcinoma than the squamous cell carcinoma or other types of the non-small cell lung cancer. Okay. Then comes the ALK mutations. ALK mutations, if it is present, we have drugs like crizotinib, ceritinib, and alectinib. These drugs can be considered if ALK mutation is there. It is seen in only around 4 to 7% of the patients, typically more common in patients who are non-smokers or light smokers and who have again an adenocarcinoma. EGFR is there, targeted EGFR medication, ALK mutation positive, targeted ALK medication. Again, among these, what is the first line recommendation if the ALK mutation present? It is crizotinib. So EGFR mutation present, first line is erlotinib, MCQ point. ALK mutations present, first line crizotinib, again an important MCQ point. Okay. Now, apart from that, you would have also studied the patients for the tumor samples for ROS1 translocations. If ROS1 translocation is present, then again the drug of choice is crizotinib. This is recommended as the first line therapy in patients with ROS1 translocation. This ROS1 translocation is typically more common in again non-smokers, adenocarcinoma, and relatively younger age. Incidence is quite less, around 1 to 2%. Okay, so the most common abnormality, especially in adenocarcinoma, that you will be seeing is EGFR mutation in almost 20 to 60% of patients. Okay, these are targeted molecules, but we have some more targeted molecules which fall in the bracket of immunotherapy. Okay, what are those? One, PD-1 blocking agents and PD-1 ligand blocking antibodies. There are drugs like the nivolumab and pembrolizumab. Pembrolizumab is considered as the first line agent among these. First line treatment in advanced non-small cell carcinoma having at least more than 50% expression of PD-1 on tumor cells without EGFR or ALK1 mutation. So most important point here is without EGFR or ALK1 mutations. If they are present, you will be using the drugs that we have already discussed, erlotinib or crizotinib respectively, right? When they are not present and PD-1 expression is there, then you can use the pembrolizumab. That's the first line agent. Again, an important MCQ point. The other drug is nivolumab. And if the PD-1 ligand blocking antibodies are to be used, the drug is atezolizumab. So this is also used as a second line treatment in advanced non-small cell lung cancers having disease progression on or after conventional chemotherapy. Side effects include rash, GI toxicity, endocrinopathies, pneumonitis, and ocular toxicity. Okay. Then you also have some role of CTLA blocking antibodies like ipilimumab, but it's not fully approved. It is right now under evaluation. Some studies showing benefit are already available. Maybe in a couple of years, it will also make it into the armamentarium for treatment of lung cancer. So I'm giving you a quick summary again. Once you diagnose someone as having lung cancer, you will see whether it is small cell or non-small cell. If it is small cell, then you will see the staging. If it is extensive disease, no role of surgery, conventional chemotherapy and or radiation therapy. If it is limited disease, you may still consider evaluating the patient for surgical exploration plus chemotherapy plus or minus radiation. If it is non-small cell, surgery still holds a place here. If the tumor is operable, in stage 1 to 3, you will definitely consider surgery. Apart from that, you will offer chemo plus or minus radiation. Chemo, conventional or targeted. Targeted is considered when specific markers are expressed. EGFR is expressed, then you have erlotinib as the first line agent, and ALK expressed, then you have a crizotinib as first line agent. Apart from that, you have a PD-1 blocking agent or PD-1 ligand blocking agent in the form of immunotherapy. Their PD-1 blocking first line agent is pembrolizumab. Pembrolizumab will be considered when the tumor is not expressing EGFR and ALK mutations and more than 50% of the cells are expressing PD-1 on the tumor cells. And PD-1 ligand blocking agent can be considered as second line treatment in non-small cell carcinoma patients who have advanced disease where despite conventional medication the disease is progressing, and that drug is atezolizumab. So that summarizes the management of lung cancer. The last point we need to know is the prognosis. right? What is the survivability of patients with lung cancer? So if it is stage 1A, the median survival is around 60 months, or you can say 5 years, and the total 5-year survival is 50%. On the other hand, if it is 1B, around 43%, 2A, around 36%, 2B, 25%, 3A, 19%, 3B, 7%, and stage 4, less than 2%, right? So obviously expected stage 4 will have the most worst prognosis. For the small cell lung cancer, which has much more worse prognosis than the small cell lung cancer, if it is limited stage, then you can say the median survival is around 15 to 20 months, so hardly 2 years. And the 5-year survival is 10 to 13%. And those who have the extensive disease is 1 to 2%, definitely less than even the stage 4 of the small cell lung cancer. So with this, I am signing off and wishing you all the best for upcoming NEET examination.